Hello, I'm Dan Brennan, and I will be speaking today about induction immunosuppression in renal transplantation. These are a list of my conflict of interest disclosures. Should we use induction in renal transplant? There is a con side and there is a pro side. On the con side, people say it's only necessarily for immunologically high-risk patients, or it could be useful for DGF, but it only decreases low-level acute rejection, and you still need triple maintenance immunosuppression. And there's no difference in long-term outcomes whether you use it or not. It also increases the risk of infection and malignancy, and it is expensive. On the pro side, it is only 2 haplotype white or Caucasian living donor recipients that are truly at low immunologic risk. It is useful for delayed graft function, and it decreases all rejection, including antibody-mediated rejection. It not only allows but mandates that we use decreased immunosuppression and principally less mycophenolate mofetil. The long-term outcomes with induction therapy do not consider maintenance immunosuppression, and infection and malignancy are increased by mycophenolate, not so much by rabbit anti-thymocyte globulin or the anti-IL-2 receptor blockers, and ultimately it is cost-effective. In a study from a long time ago, 1997, Linda Scheck showed that anti-lymphocyte induction therapy improves renal transplant survival. She looked at 247 studies and found only 7 that were randomized controlled trials in adults and compared to what then was conventional treatment of cyclosporin, azathioprine, and prednisone. 6 of 7 studies showed a benefit with induction, with improved 2-year graft survival and a lower odds ratio for graft failure, that should be. But this was with cyclosporin, not tacrolimus. So the immunosuppressive agents that we have can be divided into those that are used for induction and those that are used for maintenance therapy. On the induction side are the anti-receptor antibodies, ATGAM, thymoglobulin, OKT3 in red because it's no longer available, anti-IL-2 receptor blockers, alemtuzumab, rituximab, IDX, an anti-CD40 ligand antibody, is no longer available. Then the maintenance immunosuppression includes the calcineurin inhibitors, cyclosporin and tacrolimus, non-calcineurin, rapamycin or everolimus, corticosteroids, the antimetabolites, and then there are other things such as belatacept, JAK3 inhibitors, and maybe the sphingophospholipase receptor antagonists. Immunosuppression has changed over time. The primary calcineurin we now use is tacrolimus, which has all but replaced cyclosporin. Mycophenolate has all but replaced azathioprine. mTOR inhibitors were used early on, but now are hardly used at all. Steroids were used in almost everyone, and then hit a low spot in about 2006, but now are coming back to where it's closer to about 80% of people are on steroids by 1 year. One of the most remarkable changes is induction agents have gone from a very low rate in the early 90s of T-cell depleting agents to now where over 70% of transplant patients receive a T-cell depleting agent, a smaller percentage an IL-2 receptor antagonist, about 20 to 25%, and only about 10% of recipients in the United States receive no induction therapy. This schematic done by Phil Halloran shows that the immune response in transplantation is multicellular, with the antigen-presenting cell in the upper left-hand corner in green, and the T cell in blue, and then that it is polymolecular. And you can see the sites where various agents would block the immune system and the immunologic response to prevent rejection. So thus it makes sense that a polycellular and polymolecular approach might be better. To do this, there are polyclonal antibodies, which are used for induction primarily, but also can be used to treat rejection. These include ATGAM, a horse polyclonal anti-human thymocyte gamma globulin, and two versions of a rabbit polyclonal anti-human thymocyte globulin, thymoglobulin and the Fresenius preparation. The mechanisms are similar, with T and B cell depletion, co-stimulation blockade, adhesion blockade, inhibition of antibody-dependent cellular cytotoxicity, and induction of apoptosis. The dose of ATGAM is about 10 times what the dose of thymoglobulin is, and about 5 times what the dose is for the Fresenius ATG preparation. People have used this from 1 to, in the early days, 20 days, but most commonly people are using thymoglobulin for about 4 to 5 days for induction. Side effects include rash, a cytokine release syndrome with fever, leukopenia and thrombocytopenia, which might be part of their mechanisms of action, maybe an increased risk of PTLD, and maybe an increased risk of infection with CMV, and we'll talk about that later, and serum sickness, particularly for those who have had exposure to horses or rabbits previously. Acute rejection has dropped dramatically in the first year. These are the best descriptive data back from the USRDS in 2010 and showed that in 2005, rejection rates were around 50%, or in 1995 rather, but that they dropped now to about 10 to 12%. Notice the two lines in the solid line for acute rejection in deceased donors and in living donors are about the same. So are immunologically low-risk patients living donors? If you look at acute rejection, the answer. One of the things we hear over and over is that we have made dramatic improvements in the rates of acute rejection, but not so much in the rates of survival. This is a paper that was recently published that shows that we have made great improvements. The deceased donor transplant half-life has improved from 8.2 years to 11.7, and the living donor kidney transplant half-life has improved from 12.1 to 19.2 years. So is living donor really low risk? This is another version of the SRTR data showing a little later time period and showing, first of all, that rejection rates are similar at the first year, as we already saw, 10 and 12% in living and deceased donors, but that it keeps going up, and by 5 years it's still about they're equivalent, and now about 20 to 17%. This also shows that a kidney transplant patient is at risk for rejection for many years, although it begins to plateau, as you can see, around year 3 or so. The Elite Symphony study is one of the best studies that has been performed in transplantation. It was a randomized trial of 4 different groups, about 400 patients each. The first group received tacrolimus, or FK, with target trough ranges of 3 to 7, and induction, and MMF and steroids for maintenance. Induction was primarily with an anti-IL-2 receptor blocker. The second group was with cyclosporin at usual doses, which now we would consider to be very high, and no induction. The trough levels there were 100 to 300 nanograms per ml. The third group was with a lower cyclosporin dose, and for those programs that use cyclosporin, this is pretty much the level that is targeted after the first 3 months or so. And the fourth arm was a sirolimus group, where sirolimus was targeted at 4 to 5, and they also received induction, MMF, and steroids. What we know, and which has changed practice, is that the standard of care has pretty much become tacrolimus with induction, MMF, and steroids to produce a biopsy-proven acute rejection rate of about 12% at 1 year. What we know from this study is that sirolimus was associated with a lower CMV rate than the others. And this shows that the mTOR inhibitors actually block CMV. They don't block other herpes viruses, such as HSV or EBV, and you can see that numerically there were more and the only PTLD was surprisingly in the sirolimus arm. One of the best studies looking at which agent to be used was the rabbit antithymocyte globulin versus basiliximab study for induction in renal transplantation that was published in 2006. The design of the study was a prospective, randomized, open-label, multi-center international study with 17 U.S. sites and 11 European sites. It was to compare the efficacy and safety of thymoglobulin, 1.5 milligrams per kilogram times 5 days, so a total of 7.5 milligrams per kilogram, versus basiliximab. And the patient population were those perceived to be at risk for delayed graft function or acute rejection. There was a quadruple endpoint that was targeted, which included freedom from DGF as part of the usual FDA, freedom from biopsy-proven acute rejection, graft loss, and death. The initial study was for 12-month follow-up. It was important that the induction therapy be given pre-transplant, both pre-anastomosis, for both thymoglobulin and basiliximab, although that wasn't always done, particularly for thymoglobulin. And maintenance was with cyclosporin modified, MMF, and steroids. At a year, acute rejection was lower in yellow, 15.6%, with the thymoglobulin treated patients than the basiliximab treated patients, 25.5%. Also, there is an 82% relative reduction in the rejection requiring antibody treatment, 1.4% versus 8%. That's a surrogate for antibody-mediated rejection. Adverse events were similar. Serious adverse events were similar. Leukopenia was more common with thymoglobulin, but that's how the drug works. It depletes lymphocytes. All infections were slightly higher, and this might be explained by the fact that antibacterial prophylaxis was used less in the thymoglobulin group at 18.9% compared to the basiliximab group at 30.9%. Infection with thymoglobulin was higher. Bacterial and viral infections were higher, but interestingly, CMV infection was lower. We'll return to that. It turns out that viral infection increased, and antibacterial prophylaxis and antiviral prophylaxis were similar, except as I described previously. Malignancies were higher, but not statistically so, although there was more PTLD, but one of the PTLDs was late, and 2 patients never received antiviral prophylaxis, and 1 patient received only 1 month of antiviral prophylaxis, which has a profound effect on the development of PTLD, as shown in this slide by Donnie Funch. So that she did a matched case control study of 100 PTLD patients matched with 375 controls, and showed that the use of acyclovir and ganciclovir was associated with less risk of PTLD for every 30 days that you used it, and lower with ganciclovir because it will target both EBV and CMV. So if you're going to use lymphocyte depleting induction therapy, you should use something to treat and prevent CMV. I'll return to that later when we talk about the mTORs. In a follow-up study, we looked at who benefited most from thymoglobulin induction in the thymoglobulin versus basiliximab study. Surprisingly, the best outcomes were in recipients of normotensive standard criteria donor kidneys, not those at the highest risk of delayed graft function or acute rejection. And when you look at the triple endpoint, it was statistically significant, and that might have led to approval in the United States of this drug for induction, but it didn't, because the original study had a quadruple endpoint that included delayed graft function, which you can see did not differ between the 2 groups. Part of the problem was not everyone used the thymoglobulin intraoperatively. Biopsy-proven acute rejection was lower, graft loss was lower, and death was lower. With Mark Schnitzler, we did a 5-year study where we took the 278 patients and looked at those in the US, the 183 patients, because we could match them to OPTN data. And we were able to track down every single patient out 5 years. What we found was that freedom from acute rejection was lower, death-censored graft survival was lower, and freedom from the triple endpoint, which would have been the original FDA endpoint, was also lower, better with thymoglobulin. We found that still, by 5 years, the severity of acute rejection, measured by the need for antibody rescue, remained lower in thymoglobulin-treated patients compared to those who received basiliximab. So this shows that there's a long-lasting effect of induction therapy with rabbit ATG. With crystalentine, we looked at 10 years, and we found now that we again merged OPTN data, but we also merged this with Medicare or CMS claims. We looked at a triple endpoint of acute rejection, death, and graft loss, and there is a strong trend for it to be better despite smaller number of patients that were available. We looked and showed that the freedom from acute rejection was trended to be better even at 10 years with thymoglobulin in blue. Patient survival did not differ, death-censored graft survival did not differ, and all-cause graft survival did not differ. But we had used cyclosporin. A later French and Belgian study, called the TAXI study, looked at the use of diclizumab versus thymoglobulin in higher risk people. These higher risk people had a current PRA greater than 30%, peak PRA greater than 50%, a previous transplant, and the mean cold ischemia time was greater than 23 hours, and greater than 50% of the donors had died of a cardiovascular accident, a CVA. They were allocated 1-to-1 to receive thymoglobulin, ATG, or diclizumab, an anti-IL-2 receptor blocker, and followed up. And what they found was that, interestingly, delayed graft function was lower in the thymoglobulin, the ATG-treated patients, compared to the diclizumab-treated patients. Acute rejection was lower. Time to rejection, I'm sorry, I reversed that, was later in the thymoglobulin-treated rejections. And again, the severity of rejection, there was a strong clinical trend for it being less, with antibody treatment needed in 2.7% of those who received ATG versus 14.9%. Importantly, this was on a background of tacrolimus MMF and steroids, a more modern and contemporary immunosuppressive regimen, which is shown to be the best regimen we have according to the elite symptom. We were then able to do a study with Rita Alloway and others where we looked at the follow-up studies using a new FDA quadruple endpoint, which now replaced delayed graft function with loss to follow-up. We looked at randomized controlled trials in the bottom there, Thymo versus IL-2, Thymo versus equine ATG, my study, Thymo versus alemtuzumab, and Thymo versus no induction. And what we saw is that RATG was useful for the prevention of acute rejection in kidney transplant patients. In the upper left, in A, you have a forest plot showing that it was particularly useful in females and those who had initial transplant, and for those who are younger. In B, you see that the event-free probability was better with the RATG in red. And in C, you see the 1010 trial, the thymoglobulin versus basiliximab trial with the new endpoint, and the TAXI trial that showed it was better. And then D, you see all the main randomized controlled trials showing overall that there was a reduction in the primary endpoint using the new FDA primary endpoint. This is a complicated slide. And what this group did was they looked at OPTN living donor data from 2000 to 2012 with TAC myfortic plus or minus corticosteroids, and then looked at whether patients received no induction versus IL-2 receptor blocker versus rabbit ATG versus alemtuzumab. The results in the steroid group showed that with no induction, there were no differences versus IL-2. It was lower with RATG and alemtuzumab. In the no steroid group, there is a lower risk of acute rejection with RATG and alemtuzumab. And the results overall for allograft failure in the steroid group showed that it was worse with no induction in living donor recipients. And with no steroids, it showed that there was no difference with RATG, but worse with alemtuzumab versus no induction, but not IL-2 receptor blocker. This group concluded that RATG is preferred for induction in steroid avoidance protocols. This is a study out of the University of Michigan that didn't use induction therapy in their living donor recipients, but noted that their deceased donor recipients were having lower rejection. So then they changed and started using induction with thymoglobulin and then rabbit ATG, and showed that the acute rejection was 2% versus 48% when they didn't use induction. CMV didn't differ, malignancy didn't differ, graft failure didn't differ, serum creatinine was the same. They said costs were slightly more, but not significant. But there was a flaw in the study because they did not include the cost of biopsy, which runs about $6,000 to $8,000, or the treatment that was required for the 48% or the 46% that did have acute rejection. I told you I would return to the role of mTOR's inhibitor. Helio Tedesco Silva did this study in Brazil where the majority of patients are CMV donor positive and recipient positive, but the government does not pay for antivirals, so they paired the induction with mycophenolate mofetil, or myfortic with basiliximab on top, which had the highest rate of CMV reactivation, or they paired it with everolimus with basiliximab, which had a drastically reduced rate of CMV reactivation. But look at this bottom line, the dark line. The lowest rate of CMV activation were those who received rabbit ATG induction, and it was low dose. It was 3 milligrams per kilogram with everolimus. This is looking at the adverse outcomes, because when you talk about induction therapy, you really need to lower your maintenance immunosuppression therapy if you are using a lymphocyte depleting therapy. In this study by Vikas Darnidarka and Krista Lentine, the reference group is in yellow and is TAC, mycophenolate mofetil, or azathioprine, very few used it, prednisone, with thymoglobulin induction. So that's what everything is compared to. So the colors are pretty, but it makes sense to look at what was seen overall. With the use of sirolimus, there is more pneumonia, sepsis, NODAT, acute rejection, death-censored graft failure, death, and interestingly, no benefit even for cancer. If you use the steroid-free regimen, there is less pneumonia, sepsis, urinary tract infection, and NODAT, new onset diabetes after transplant. With cyclosporin, there is more pneumonia, skin cancer, and NODAT. In conclusion, polyclonal lymphocyte depleting induction with thymoglobulin makes sense mechanistically and is effective, safe, and economic. Taken together, randomized controlled trials and meta-analyses show that induction with thymoglobulin results in less acute rejection and better long-term survival than ATGAM and IL-2 receptor blockers, or no induction, despite indication bias where it would be used in those perceived to be at higher risk. Polyclonal lymphocyte depleting induction to minimize maintenance immunosuppression is underutilized. Thank you for your attention.